I'm going to talk about overcoming the post LASIK challenge with Elon EDOF. And if you miss the mark, then also consider the add-on IOL. So I have a lot of ground to cover. I'll be going quite quickly, but feel free to speak to me afterwards if I went too quick. So LASIK became popular during the late 90s, early 2000s. And we're really seeing these patients reach cataract age. So it's becoming a bigger issue than it used to be. And it will continue to be a significant issue for us for decades now to come. Steady increase. And these patients are younger. They're more visually demanding. They're patients that sought out spectacle independence in the first place to have their LASIK surgery. So they are expecting spectacle independence. And we know this can be more challenging in this group of people. So the challenges are around IOL calculations. Of course, we hit the target less often. There can be dysphotopsias and visual quality issues from the corneal reshaping or ablation. These patients often have dry eye or ocular surface issues and can have weaker or irregular corneas, especially with the earlier LASIK treatments from 20, 30 years ago. And so we have to manage their expectations. And it's not just technical challenges, but also communication challenges. And these patients do take more chair time. So I like to give examples by case studies. So this is a post-myopic LASIK patient. This is her right eye. This is her left eye. She'd undergone a hyperopic shift because of the presbyopic changes and then the hyperopic changes. And in the right eye, there was minimal astigmatism, but there was a significant degree of astigmatism that required correction in the left eye. And for these patients, I'll always look at the higher order aberrations when thinking about a presbyopia correcting lens, and also carefully look at the spherical aberration because that will guide which EDOF I might use. But the Elon EDOF is neutral, so you don't have to think too hard about it. So she underwent bilateral, non-simultaneous cataract surgery aiming for planar in both eyes, and these are the results. So at 1 month, doing quite well in the right eye, 6 on 7.5 minus, N12 for intermediate and near. And at 3 months, this had settled further, particularly the intermediate and near vision, reaching N6 for near and N10 for intermediate. Similarly, the left eye was a little better, reaching 6.6 at 1 month. And what you notice here is at 3 months, also reaching N6 for near and intermediate in the left eye, is that it does take 3 months for these lenses to fully settle. And so while traditionally we tell our patients to go get glasses at 1 month, my experience across the board with these more recent presbyopia correcting lenses, especially all the EDOFs, is they do take a little longer. So that was an excellent result. Next patient, post-hyperopic LASIK. She didn't have a cataract. She was a clear lens exchange, but we lived a very active lifestyle, 56 years old. Had hyperopic LASIK, which not unusually regressed. She had a retreatment and she underwent further regression. So you notice her spherical aberration is negative. So with the hyperopic treatments, it can be either very low or negative. So you particularly do not want to use an IOL that induces more negative spherical aberration in this case. My concerns in this case in using positive spherical aberrating EDOF lens is that you lose the effect of the EDOF because it's using positive spherical aberration and you don't get any positive spherical aberration. You just neutralize the negative spherical aberration. So I prefer in this case to use a neutral EDOF again. So she had her right eye done with another EDOF. We just had problems getting the power in the time that we wanted to do the surgery. And then she was a good candidate for mini monovision. And I had aimed for minus 0.75 in her left eye using an Elon. I actually hit plano, but she was very happy. We reached 6.6 for distance, N4 for intermediate, and N6 for near. So these are two post-LASIK cases, one myopic, one hyperopic, that particularly had excellent results with an EDOF. And she gained binocular glasses independence and threw her glasses in the trash bin. The defocus curves really do speak for themselves. So the orange curve is targeted to plano. So we have a good breadth of this defocus curve to about minus 1.5, which is what you would expect with a full EDOF lens. Not all EDOFs are full EDOF. And then in mini monovision, which I don't do routinely, but I do in the patients that I think is suitable, then of course we get the wider range of defocus to about -2. So you really can get patients independent of spectacles for most tasks, unless they're doing very fine detailed things. So my strategies are, of course, to thoroughly assess the ocular surface and treat dry eye before surgery, because we know this is so important for our biometry. I base my IOL decision on topography, angle alpha values, high outward aberrations and spherical aberration. And I really do weight towards the modern calculation formulas. And I probably weight more towards Barrett-Trouquet for these post-LASIK patients. And then choose the IOL type cautiously and take into consideration those additional things that are needed with the post-LASIK eyes. And we need the patient counselling. So there is an increasing number of patients presenting with prior corneal refractive surgery. And I'm not talking about RK here, I'm talking the more common laser vision correction patients. And excellent outcomes are possible if we use the right formulas, we plan the surgery well and communicate clearly to the patient. And my go-to lens is Elon because it's neutral, it gives good results, it offers a balanced solution with the dysphotopsias versus the range of vision, which is not a full range usually in plano, but it's a very good range. And in mini monovision, of course, you can get the full range, and it's well suited for many post-LASIK eyes. So now let's talk about missing the target. And I did miss the target with the post-hyperopic patient. I had aimed for -0.75, but I just was lucky that she got plano and she had a good result and she's very happy. So let's talk about refining the target when you don't hit it, which is more common with the post-LASIK eyes. So the 1stQ AddOn lens is a secondary sulcus supplementary lens that is specifically designed for the sulcus in a pseudophakic eye. So not when you've had a complication and you need to put a sulcus lens in where the patient's not already pseudophakic. And you can put the lens in at the time of the original cataract surgery. That's a dual lens procedure. Or you can put it in down the track, even if there's been a YAG laser capsulotomy, but with more caution in that space. So it comes in a monofocal sphere, a monofocal toric, a trifocal sphere, a trifocal toric, as well as a more novel use of the Charioth macular lens, which is a high mag, which is great for both dry AMD patients. Our Asian counterparts are using it a bit more in their Chinese patients that want to see the really, really tiny Chinese text. Monocular, they're using it in one eye only. So it has a great sulcus fit. The main thing is the haptics, the way they're designed make this lens incredibly rotationally stable. I have not had a single rotation with this lens, whereas other ones I've had rotations and the toric versions just aren't stable enough. So it really is a get out of jail free card. It can be used, as I said, as a single dual lens procedure. Why might we use this? Well, there may be a patient that they're not sure about multifocality. So if they're a green light for multifocality, both personality-wise and ocular parameters, I'd just put a multifocal in the back. If they're a red light, I'm not even going to consider if they've got macular abnormalities or they're just not going to tolerate the halos and flares. I wouldn't bother thinking about a dual approach either, or a multifocal in the back. But if they're a yellow light, some patients don't know what the halos and flares will look like. Some patients are a bit dry, you're not sure how they'll tolerate it. For that yellow light patient, the reversibility is great because you can take it out. If you think that their eye is going to change, if they might need a future PK, if they're actinic, you might want to change the astigmatism correction down the track. So that's another reason why you might put in a toric as a dual. You can also use it as a secondary delayed procedure, and that's probably the most times I use this lens to refine the refractive outcome for either sphere or SIL, especially the hyperopes where it's harder to laser them. For irregular corneas where the keratometry just isn't making sense and you need to wait till post-operatively to get their astigmatism correction with the subjective refraction. Or if they've had a either non-toric lens or a monofocal lens and they want a vision upgrade, either for distance and you just put in a toric to refine the visual outcome, or you can put in a multifocal because they may not have been offered that at the time of their surgery. More novel uses is if there's a hydrophilic lens in the bag and the patient needs an air bubble in their eye, for example, with a DSEC, you can put a plano add-on in to protect that hydrophilic lens in the bag. Then if the add-on also hydrophilic opacifies, you can take it out and you don't have to do an IOL exchange. And then sometimes patients do change their mind with their refractive target. You give them monovision, they hate it. You can change it and make them plano both eyes with or the other way around. So laser doesn't do everything, and the significance of dry eye should not be underestimated in terms of laser vision correction. And I never intended to become a dry eye expert, but I did so much laser. It takes a lot of chair time to treat dry eye patients. So we want to avoid that, and we can avoid that. So there are some requirements. You need to have enough anterior chamber depth, and that can either be a phakic measurement or a pseudophakic measurement. And you can measure it externally, like on your IOL master, or internally if you have the capacity to do so, for example, with a pentacam. Again, an example we can see for the topography here, we've got a bit of a marginal pellucid degeneration appearance. And when I measured this patient's keratometry, it was wildly different. So I was wearing plus 3.5 seal in the glasses, plus 5.7 on the pentacam, and plus 7.8. So I was like, well, the axis wasn't too bad, but it was different enough that I just was going to be like pin the tail on a donkey. So I aimed for planar with a monofocal non-toric lens in the bag. Post-operatively, once stable at 1 month, get true measurements, at least 2 weeks apart, of the subjective refraction. The refinement is based on the subjective refraction. I put in a monofocal with sphere and seal to refine the refractive outcome. He was 6.15 after his first surgery, not super proud of that, but knew I was going to have 2 bites of the cherry, and got him to 6.6 with a monofocal toric AddOn. So this is how to load the lens. Most people are familiar with the Medicell injector, and you can practice this at the booth because we're running short of time, but there's a little notch on this lens, and I do load this lens. I don't leave it up to the nursing staff. It's just a matter of getting this lens into the cartridge, tucking it in, making sure that those haptics are tucked in underneath the little flange of that Medicell cartridge. And there are a few other tips and tricks that you want to be aware of before you implant this lens, in terms of setting yourself up for success. And I'm happy to talk to you about those. And then this is actually an insertion of, you can see that there's a monofocal toric lens in the bag. This is I don't know if this is a jewel. It looks like a jewel because there's no capsular phimosis of the original lens. And I will IA all the viscoelastic out and start again and put more viscoelastic out from the capsular bag, put more viscoelastic into the sulcus and on top of the lens, put the lens in. This is a multifocal, so this is a dual in one day, and that's a multifocal lens going in. We're out of time. Feel free to approach me for questions afterwards. Thank you.
Welcome, everybody. I'm happy to be labelled the 2-lens guy. I will suck it up and absorb it, and I'll tell you why that I'm willingly happy to use simultaneous or consecutive 2 lenses in certain circumstances. So in general, I'm still doing 60% monofocal toric. I'm doing about 20% EDOF and 20% multifocal. My WOW lens, without a doubt, is the Liberty multifocal, and I'm happy to say why. It has very little dysphotopsia, and I would even say it will compete with EDOFs in terms of dysphotopsia symptoms, and its defocus curve will outperform an EDOF and guarantee you distance, intermediate and near vision. So why do I use multifocal IOLs? Those who wish for glass independence, they walk in the door, they say, I just don't want to wear glasses. So now you're up against it because we need to find a solution. Patients are inquisitive. How do I get glass independence? Oh, I don't mind glasses. People having difficulty with glasses due to facial anatomy, and they're sliding or get dirty, and they have issues wearing glasses. And obviously contact lenses. Glasses posing as an occupational hazard. These are people who may be doing woodwork or electricians, etc. Can be very difficult for them. And I very much embrace neurodegenerative disease. as multifocals, for these are people who need to be stimulated. They lose their glasses, and if they have good point focus wherever they're looking, that can add quality to their lives. So if we look at the diffractor family, the outlier is the Liberty, based on 7 rings centered on the first 3 millimeters, whilst the other competitor product, and I've used every single one of these, has a much larger number of rings extending further out, and that's why they have more dysphotopsia. So the AddOn portfolio, Alison's spoken about: spheric, toric, trifocal, toric, and SML. I'll talk about SML as the macular lens. I put in about 5 or 6. In the exact circumstance, it works unbelievably well. So someone's got limited vision, 612 to 618 in their best eye, count fingers or whatever in the other eye, and you know they got a stable scar, like in a macular dystrophy, a vitelliform, and they got issues with magnifiers and glasses. This SML lens lets them read glasses free, very close up at 15 centimeters, and empowers them to know that they have some reading ability. So it's very valuable. So with dual lens system, well, I'm going to skip most of this because Alison's mentioned this. The point is it's easily reversible, it's very stable, and you can do it simultaneous or consequentially. So I did a study on comparing a dual lens situation in those patients who might have been borderline for Liberty or weren't quite sure, should I really have this opportunity of the multifocal? So instead of losing that opportunity, I said, well, we can have a reversible option. We compared this to the Liberty in the bag versus the multifocal add-on outside, and there was literally no change in data. One thing that I personally noted is that the rings of the add-on, there's 6 rings, not 7, are closer to the pupil centration that sometimes in the bag IOL would do. So I never once saw the multifocal add-on decentered, never. And occasionally with multifocal diffractors, you see those rings sitting slightly decentered and you get anxious, is this going to create more dysphotopsia or not? But I can vouch for the add-on being extremely centered. So inclusion criteria for the add-on, Alison's gone through that, so I'll skip this one. And just in general, multifocals, if I'm using 20% of my WOW lens, it's because I've ruled out so many others, right? You have to do the hard work, which is thorough diagnostics. You've got to do a good refraction. You've got to take pupils. You've got to measure the pupils. You've got to do a Pentacan. You've got to do an Optos. You've got to know a CT. And you've got to look at all the values that would say, I'm sorry, you're not suitable for a multifocal. Hence, that's why my multifocal load is small, yet the satisfaction's so high. When you select well, you get good results. So what about the borderline cases? We know we should not use a multifocal. Patient says, well, can I please have an opportunity? I'd love to not be in glasses. So top left, you can see an epiretinal membrane with a total vitreous detachment. This membrane is quiescent. There's no one that's going to involve traction and growth. And as you can see, you have a normal foveal pit. I'd say, right, you could be a reversible option. Top right, we got some early macular edema, non-centered macular edema that you control with your anti-VEGF therapy and improved diabetic management. You can get long-term good outcome. And if we get into trouble, you can put the lens out. Once you get center fixation or foveal involvement, it's a complete no-no. So case study 1, this 51-year-old lady, she walks in and says, I don't want to wear glasses. I'm a professor at university. I'm an actress. I do public speaking. I use a computer. I'm not wearing glasses. That's her words to me. So I said, well, you can't always choose. She said, well, if you can't do it, I'll go to someone else. Well, then I went through it with her saying, look, you're mostly not wearing glasses. It's only for close work. She said, exactly. I don't want to wear glasses. So we went through everything. She was a perfect candidate. And this was an RLE with a Liberty. And the outcome was exactly what she wanted. Total satisfaction. 6.6, N5, and intermediate and near. And all her parameters were aligned. Her angle kappa was extremely close to zero. I think angle kappa plays a big role in diffractive IOLs. The closer it is to zero, the better outcome you're going to get. The limit is 0.5, and then you would have warnings. You may get ghosting, you may get more dysphotopsia, and of course, corneal spherical aberration values, there are limits. This is a bit of a joke, this slide, because we asked the Liberty patients, first of all, are you wearing glasses? 0%. 0% of that cohort are wearing glasses. Secondly, who's getting dysphotopsia? At least 50% said, I don't get dysphotopsia. Of course they get dysphotopsia. They may not notice it or they may not embrace it. They have evolved that they feel there's no dysphotopsia. So the important thing is it splits light. If you split light, you lose light. You have to tell them, you're going to a tunnel, it's going to be dark. If you're driving on the open road without lights, it's going to be difficult. You will adapt and you'll have to use high beam, etc. So splitting light loses light. If they are reading in this environment, it'll be adequate. But if it's darker, like in a restaurant, they'll have to add light. And that's acceptable. You bring your phone light out and off you go. You add light and you understand that that's how the lens works. You explain it well. Case study 2, this lady had Sjogren's syndrome, diabetes, and her tear film was not great. And she said, I'd really like to have the opportunity of freedom from glasses. So after a lot of counseling, we spent an hour to 2 hours with some of these people. Okay, we'll do the add-on Sulca's reversible option. Her cornea was borderline. She had angle kappa of about 0.37. That's fine. But her corneal spherical aberration values were slightly high. And she got the outcome she wanted. She got 6. I've got 5 years of follow-up on her. 6 in the end after a year cap and reading N5. So the message is simple. The add-on adds reversibility. Cataract surgery equals opportunity. If you lose the opportunity, can you regain the opportunity? Yes, you can. You can put an add-on later on in a monofocal. Or if the multifocals aren't happy, you can remove it. So there's your reversible option. I can promise you it's low dysphotopsia. I totally believe that. The dual system is in those difficult cases. And that's all I have to say. I think we'll just open up to chats and discussions.